Welcome to Healthline3. I'm Jade Balexa. October is Breast Cancer Awareness Month, and we have a doctor here to bring you some important information about detecting it. Dr. Prakash Peddi is a hematologist oncologist with Willis Knighton Cancer Center. And Dr. Peddi, thank you so much for being here.
Oh, thank you. Thanks a lot.
Absolutely. So let's just start from the beginning. Tell us, what is breast cancer?
Essentially, if you really want to have a deeper meaning of this, cancer is essentially abnormal growth of cells which have no containment, and they essentially spread to a point that it can, or it has an ability to compromise your life. Breast cancer is a type of a cancer where essentially it starts off with either in the milk gland or the milk duct, okay, and from there it keeps on growing, and it can present in few, I would say in a few lucky women as lump, and most of the times it is diagnosed and detected by what we call as screening mammograms.
Mm-hmm. And so, can you really tell the difference between a lump and a tumor?
It really depends upon the age group. For example, let's say there is a 20-year-old woman who's having lumpy breasts and it changes during the cycle or during the month. Well, it can be mostly it is benign. Mm-hmm. It is hormonal in nature. But let's say if you're talking about a 60-year-old woman and suddenly she finds a lump, it needs investigations. It needs investigations immediately. You cannot ignore it, because the chances of something of that so-called lump turning into what we call as a cancer is very high in this bracket of women. Okay. So you cannot, we as doctors don't tend to provide assurance on the lumps. We tend to tell them that it's time to go and get it checked.
So it's more likely to be cancerous when you're older?
Yes, yes, and especially if you don't have that to begin with. You know, anything what we call as a new onset lump is, well, I don't want to go to an extent saying that it is cancer unless proven otherwise, but mm-hmm. again, it needs to be seen with an extreme caution.
Mm-hmm. So tell us, when should someone start screening for breast cancer? At what age is recommended?
There are a couple of factors. If you look at regular, what we call as not so high risk women, we start off with advocating breast mammograms every year, starting at the age of 40 years, okay, and every year. And especially, let's say if there is a woman who has a strong genetic predisposition, or what we call a strong family risk, and she carries inherently a genetic risk that she's at high risk of breast cancers, we tend to start them as early as 25 years. We start off with essentially an MRI, and after 30 years we start on mammograms every year. Okay.
So high risk would mean they have a genetic...
Yeah, so many people, at least some people, are aware of what we call as a BRCA gene, breast cancer mm-hmm. gene 1 or gene 2. If you have any family member, especially mom or an aunt or uncle having that, it tends to put patients at risk of acquiring this, and again puts at a risk of them presenting with breast cancers in their lifetime very high compared to the rest of the population. For example, let's say if an average woman up to 95 years has a chance of 1 in 8 having some form of a breast cancer, if patients with what we call as a BRCA1 gene, their risk can go up to 70 to 80% in their lifetime. But it all, again, so for the audience, I think I want you to know that all these things that I speak, there are a lot of nuances to this. This is not a definite thing. Critique is there at every step, but I want you to understand that what I'm talking is generalizations here. But yes, the risk can be going up to almost 80% in some subset of people.
Mm. Okay, so what type of screenings are available for people out there? I mean, you mentioned MRIs, and yeah. That would be for people who are high risk, right?
Yeah. So for most of the women, what we call as 2D mammogram works. There is push towards getting 3D mammogram, which has probably a little bit better resolution, and what we call as a few callbacks. Some women know that when they get a mammogram done, they get called back and says, all right, we need to do a diagnostic mammogram this time to have a better clarity. But probably the 3D mammograms, you don't tend to do that much. That is for an average risk woman. For women who has very dense breasts, who are on the younger aspect, or let's say around 30, 35, who have very, very dense breasts, when we feel that mammograms might not do complete justice and there is some chances of missing some tumors, MRI is very, very sensitive. So, but that topics are kind of decided by on a case-by-case basis with your primary care doctors, or what we call as a surgical oncologists or breast surgeons, who get involved and actually take it from there.
Okay. And so what happens if you're called back for a diagnostic test? I mean, does that necessarily mean that person has cancer?
Absolutely not. The whole purpose of diagnostic mammogram is to have further clarity. Luckily for most women, most of the diagnostic mammograms generally turned out to be negative, or a false alarm, so to speak. Let's say there is a diagnostic mammogram done, and let's say that there is a new thing or new abnormality that they find. Even then, it doesn't guarantee that this is cancer. It could be precancerous lesion. It could be some other forms of what we call as precancerous lesions, or obviously it can turn out to be even cancer too. Once you have a diagnostic mammogram, the breast radiologists, the breast surgeons get involved in the cases. They take it further notch up. They do an ultrasounds, they do biopsies, and only when it is either a precancerous or a cancerous lesion, that is where I come into the picture.
Okay. And so tell us, does early detection of breast cancer affect treatment options?
Yeah, absolutely, and I think that is the reason for pushing mammograms and pushing any screening maneuvers, right? Whether it is a colonoscopy or a mammogram. There used to be a time where we used to always, and that is where the confusion started with mammograms, where people used to say it does not lead to better improvement in overall survival. It doesn't have to be overall survival. It also can mean less suffering. For a woman, most of the women who come to they're very much obviously relieved that the fact that they do not have to go through chemotherapy, right? So there are some situations where the size kind of matters in our decision towards chemotherapy. Not all the time, but it does matter to a certain extent. So there are multiple cases that we come across. Luckily, they get diagnosed with very, very small tumors, and they really do not need any chemotherapy or any kind of aggressive treatment that bothers them in a short term as well as long term. They might just get away with a very simple surgery, or maybe just a radiation, and get done with it.
Okay. Yeah, I'm hearing more and more people not having to do the chemotherapy, and I'm sure that's what the patient would prefer, because chemotherapy always makes people feel bad.
Not really.
No?
I'm not saying this because I'm a medical oncologist, but we are still reeling from the effects of 1990s and 2010s. There are a lot of good supportive measures that we help people with to lessen the side effects of chemotherapy. Yes, I am aware. I'm very keenly aware of the side effects. If I was a patient, I would definitely want to avoid chemotherapy if possible. But when they clearly understand that all the chemotherapies are not built on the same level.
Okay.
There are some few aggressive treatments that we do in the breast cancers where we sufficiently warn patients that yes, these are the side effects that can be expected. But many patients, by and large, do very, very well.
Okay. And so tell us about the stages of types of breast cancer. I spoke to one lady recently who is living with stage 4 cancer, and she's lived for many, many years, and had want people to know that it's not necessarily a death sentence. And so just talk about the different stages there.
Well, like most of the cancers, there are stage 1, stage 0 when it is a precancerous. Stage 1 is when it is small, under 2 centimeters. Once it has spread to the lymph node, it becomes stage 2. Once multiple lymph nodes become involved in your armpit, or when the size of the cancer is much bigger, you call it as a stage 3. And once even if a spot or a speck goes into any part outside the breast area, you call it as a stage 4. You're 100% right, and that's the most of the women unfortunately come to the reality check when after talking to us, and sometimes they have to live through it to experience it. You're absolutely right. There are a lot of patients with, and not with us, but in any part of the world, where patients have been living with what we call a stage 4 breast cancer for decades. I'm sure, I think I have with the colleagues that I worked with, there are some patients carrying on for 15 years, 17 years. You just do not know unless you start where the story is going to end with, as to how long you're up to. There are some type of cancers where the survival is really, really long, but there are some cancers where survival is definitely limited. It's a little bit scary on those subtype of patients, but most of the patients do well.
And we have Willie on the phone right now. Willie, good afternoon to you. What is your question for Dr. Peddi?
I want to know, when you get 88, do you still need to take a breast cancer test?
Can you repeat that?
When you turn 88 years
When
old,
I'm 88. Do I need to go get a breast cancer?
does she still need to get a breast cancer
Dear,
screening?
how healthy are you? If you're strong, if you're healthy, yeah, get it. If you think that there is no other reason to be, if there is no other health condition in you that can dominate your life quantity, I think you should get a mammogram. Some breasts are
I should still continue to get what?
So there is no upper limit. I have a patient who has 102 years who comes to my clinic. Where do we stop? Yes. So it all really depends upon how good of a quality of life that you have. If there is already a patient with stroked out, sitting in a wheelchair, and a lot of other people taking care of her, then you have to still wonder what is the point of doing mammograms. But if you're healthy, I would advise you to get it.
I thank you so very much. That's what I'm wondering about. Should I go? I've been getting it all my life. Thank you.
Thank you.
Yeah, that's a great question for sure. Yeah.
Yeah, there is no ceiling point. There are some patients, just the age is ever evolving. You can have a 90-year-old who looks like a 50-year-old. You have a 50-year-old who looks like a 90-year-old. So there is we do not draw line based only on age. Yes, it matters in some situations, but that's not the final point.
Yeah, it could give you a peace of mind, no matter your age, to get a screening. Okay, so how do you treat low-grade cancer versus high-grade or advanced cancer? And we talked a little bit about this earlier. Radiation, chemotherapy. What are some treatments?
So there are multiple approaches to treat a breast cancer patient. One such first approach is surgery. When possible, if possible, you do surgery. The second line of treatment comes in terms of radiation. The third line in terms of chemotherapy. And the last important type also is what we call as hormone blocking therapy. When someone tells you it's a low grade or small tumor, what they're trying to tell you is that probably there is not much role of chemotherapy in their case. The breast cancer is again a little bit complex, and many women have a feeling that all the breast cancers is the same. It's not. I'm telling you, it's not. For example, there is a patient with 2 centimeters tumor who can end up in getting chemotherapy, versus a patient with 7 centimeters tumor who might not get chemo. It all depends upon how aggressive the tumors are. If it is enough aggressive, we do all of the treatments. If it is less aggressive, we might limit just radiation and even just the surgery.
Good afternoon to you, Jacqueline. What is your question? Are you there?
Catherine.
Catherine. Hello, Catherine.
Hello.
Yes, I have a question. I don't know if this is a myth or not. Can you get chemicals like perms in your hair once you had breast cancer?
Are you asking if the perms can cause breast cancer?
Will it contribute to it?
So there are a lot of chemicals which can in some way influence the possibility of breast cancers. Okay, there is we don't believe that there is only one single thing which can cause or put women at risk of breast cancers. At some point there was a controversy of using deodorant sticks, makeup kits. You have to understand that there are a lot of these chemicals which have been stated as hazardous in terms of cancer causing chemicals in the state of California. To answer your question, most of these are all right. You have to really see there is no single thing, Catherine. You can be smoking and you'll be just fine. But let's say that there is a 20-year-old who smokes till next 30 years, she might end up in get breast cancer. But that's not the only reason. We are always taught that there is always one single reason, but it is much more complex than that. I would not advise anyone to use unnecessary chemicals if they don't have to. But on the point is, if I don't think there is one single thing. It's a combination of everything. Okay.
Okay. Thank you.
Welcome, dear.
That's a good question. Okay. Yeah. So when does someone have to do chemotherapy versus radiation therapy?
Okay. So there are some certain types of breast cancer where we call them as a triple negative breast cancers, or there are certain other types of breast cancers called as HER2 positive breast cancers. These, by default, unless the size is so small, most of these patients will end up in getting chemotherapy as a precautionary measure for them to come back, for them not to come back. There are some patients with what we call as hormone positive breast cancers. Mm-hmm. Almost 70% of them do not need chemotherapy, because these are the patients who we call them as a low grade or low risk patients. Okay, so all they would need is probably endocrine or hormone blocking therapy. When you utter the word high risk, what it really means is the chances of that tumor causing immediate trouble is high. The chances of that tumor coming back in the future is also very, very high. Those are the patients we take these high risk groups and make them low risk, or at least attempt to make them low risk by giving them chemotherapy. Radiation, not to go into the too many details of it. For example, if a part of the breast is removed for a cancer, inevitably I think the recommendation which comes after that is radiation. You can give it anywhere from 20 days to 30 days. Okay, it used to be 35 days. Now there is more focus of getting it to 20 days these days. But let's say if the woman has complete breast removal, good chunk of people can be spared of radiation, unless the tumor is very large, and then we still do radiation.
Mm-hmm. And tell us the difference between DCIS and invasive cancer.
Okay. Most of the women or most of men must have heard the word polyp, right? When you have colonoscopy, your doctor removes polyps, and that's the whole holy grail of doing a colonoscopy. You do this, you remove the polyps which are emerging, because these are the polyps. These same polyps might put you at a risk of colon cancer at a later point. I know that we are not talking about colon cancer, but breast is almost like that. Nothing comes in a matter of 1 day or 10 days or 1 month or 6 months. It takes time. There are a lot of changes that happen in the breast slowly, and one part, at certain point, we see what we call as DCIS. It's a pre-cancerous spot or lesion, or what we call as a lump that can come, and essentially the treatment for that is you need to remove it, and you probably end up in radiation if it's only part of the lump is removed. But if there is a chance that this so-called pre-cancerous spot might harbor what we call as cancer. When you use the word cancer, I tell my patients that the most important thing to know about cancer is it can go and it can grow. It can go. That's the whole point. And the precancerous, it should not. It should stay in one place. But ultimately, if that is not attended in time, and that brings about another question of early detection. We try to catch up things early in the time, where hopefully it has not turned into cancerous, which has the properties of going to places. That is the main difference. One can move and one will not move.
And let's talk about some of the population risks. Who typically gets breast cancer and all that kind of stuff? Family members. Tell us, we talked a little bit about the ages earlier, but, men get breast cancer too. So let's just lay it all out there.
Yeah. It's a very broad question. So imagine 30 or 40 different things, or 30 different reasons why one can get a cancer. For example, let's say there is a woman who is smoking. Let's say there is a woman who is also drinking alcohol, and let's say that she has genetically or has a strong family history of breast cancer. Now, not only the family history of breast cancer drives her to have a breast cancer, but all the other habits come into play. They interact, and we don't kid when we tell the patients that there are these 30-40 different things interact in multiple thousand different ways. And that's the reason we never tell patients this is the reason why you got breast cancer. For example, having less vitamin D, having a strong family history, smoking, alcohol, bad genetics or different genetics, not having no opportunity to bear children, sometimes being on the contraceptive pills. That is a matter of controversy, but that is still there. Being on what we call as hormone replacement therapies can all in some way or fashion increase the chances of breast cancer. And when you combine with poor quality of food, poor exercises, or too much of weight gain or obesity that is rampant in our society, all these things can again increase the risk of breast cancers.
And we have Joy on the line right now. Joy, what is your question? Hello, Joy.
Yes. This is Joy.
Yes, Joy, go ahead with your question.
I wanted to know, I tuned in late, but I wanted to know if you could tell me what Crohn's disease is.
What, did you say Crohn's disease?
Hello?
Yes, we're here. Say your question again.
I wanted to know if you could tell me what Crohn's disease is.
I think she said, what is Crohn's disease? Can you tell her what that is?
Crohn's disease is outside the breast, dear. Okay. This is a well, I'm not a GI doctor, but essentially it's an inflammatory disease in the colon. It's not necessarily in the breast. Okay.
Thank you, Joy, for calling. So I've heard about triple negative cancer. What exactly is that?
Triple negative breast cancer is what we call as one of the most aggressive, fast-growing, resistant type of a form of a breast cancer. It is a breast cancer. It's just probably one of the difficult ones sometimes in some clinical situations. Essentially, these are younger women who are in 30s, 40s. African American females are disproportionately affected a little bit more. But regardless of the race or ethnicity in which it occurs, it tends to have a very aggressive course. Most of these patients, at least good part of these patients will have genetic predisposition. The younger they are, the more they have a genetic predisposition to get into these type of a cancer. And these type of the cancers are the ones which will end up in requiring all of what I told you before as to surgery, radiation, and chemotherapy. Chemotherapy, unfortunately, is a predominant path to have a curative intent on these patients. While might other type of, especially hormone positive patients, might escape chemotherapy. Unfortunately, we do not have enough. I would not say data, but we don't have enough trials to prove that we can get away from the chemotherapy at this point for triple negative breast cancers. And not only that, they tend to have disease which comes back in other parts of the body, and that's the reason we tend to treat them very aggressively. In all when you compare to all the type of subsets, even though we made very good progress, we are not there yet.
Oh, okay. Well, we'll definitely keep up with that for sure. Okay, Diane, what is your question for Dr. Peddi?
Oh, hello. How are you doing?
Good.
I've got a question. Okay, I'm getting an echo here, but what causes them to multiply? Now, my lymph nodes were already when that somebody checked that in your breast, yeah, because I got like at least three. Then they checked my lymph nodes; they were inflamed, but they said I didn't have cancer. But what causes them to multiply like that? And my breast got enlarged.
What causes the cancer to multiply, dear?
Yeah, the tumors. They are tumors. Yes.
So, if you just look at your skin, okay, just look at your skin and all, you don't, most of the, I mean, it is a flat layer of skin, you don't see any multiple lumps or bumps or spots which are coming out of the skin, because all of these cells of your body.
Every one of them they are tumors though, that's already been.
So the whole, what happens in tumors, or what we call as cancers, is the body does not have any control of their growth anymore. So they keep on growing and multiplying all the time, and they grow and go to such an extent that they become a problem.
Well, they told me that the lymph nodes were inflamed. What causes that if it's not cancer?
Can you repeat that question, dear?
Can you turn down your background noise?
Okay, there you go. Okay.
Say that question again, please.
Okay, they said my lymph nodes were inflamed, but what causes the lymph nodes were inflamed, but they're still multiplying in my breast.
Okay. Well, what happens with most of the cancers is it's like an interstate. They have to go somewhere. They have to find a road to go into other parts of the body. One such road or route is your lymph node, okay? The first area in which the cancer grows is into the lymph node, and that is where it multiplies. And from then it can go into other places too. But not all the nodes which are inflamed or are becoming bigger, they don't mean that they have cancer. It's just that we have to prove it.
Okay.
We have to do a surgery and prove it. But not all the masses in the lymph node are cancerous, dear.
Does that help?
Oh yes, that does help, because I've just been really worried,
Mm-hmm. All right. Well, thank you for your call.
And
What's the next part? Okay. All right. Well, gosh, this has been very informative, and we've gotten some great callers today. Kind of give us some information to wrap things up. What else do you want people to know before we end the show?
The first thing is don't depend on other people's notion of what the lump that you feel. First of all, get screening mammograms done. If you feel anything abnormal, get it evaluated. Make sure that someone examines you. There are time and often I see patients not getting examined. Please get it examined and get it to the next level. There are a lot of good surgical oncologists in our town who can take care of your patients, and there are excellent breast radiologists who will be of immense help.
All right. Thank you for watching.